Hi, thank you again. I think this is part of the standard union card to be a transplant physician or surgeon, so I can get through most of these slides. I am not Dr. Mohan. I don't play him on TV, but I'll try to do the best going through the slides. I know the group at Columbia very well, and I'll tell you that we all present with our bias, and I will safely say that probably my bias and his are a little bit different, but that's okay. We'll see if we can get through the slide deck. So he had these disclosures. I have no disclosures to make. And very common slide. We all know the prevalence of folks on dialysis is much greater than those with a transplant, though the green line with people alive with a transplant is growing nicely. And I use this slide actually when I talk to non-nephrologists, general surgeons, et cetera, to tell them they're going to run into people with a transplant in the emergency room, and they're going to come in with other things, so they better know where the organs are not to cut through them. And as you see, that is occurring in the country. We all know that the cost of end-stage renal disease is expensive, about 1% of the Medicare population, with a cost over 8% of the Medicare program. We also know the 5-year outcomes from all-cause mortality is better with a transplant than without a transplant if you have end-stage renal disease, and especially as we get up in age. This is an interesting slide, and I love this slide because it compares having kidney disease with cancers. And people always want to say, well, it's a big surgery and we got to go at it because they have a cancer and they're going to die. And we talk about end-stage organ replacement, whether it's kidney and or liver or others, and how it is such a risk on patients' longevity. So again, the question is, how can we try to improve this and then move up from the hemo or the peritoneal red lines up to the transplant lines, both deceased donor and living donor transplantation? The Medicare cost per modality, you know, this is of particular importance right now. And actually, as a public service comment, I'll mention that before Congress right now is, once again, the immunosuppression drug coverage bill. It's been sitting in Congress for a couple of decades now. The CBO has never been able to actually look ahead and say we're going to save a lot of money. They weren't able to project that they would save $60,000 a year per patient. They could only say it was going to cost us $30,000 more per patient. So finally this year they were able to say that if Medicare goes ahead and pays for immunosuppression, because as you know, those who get a Medicare transplant only because of having Medicare for their end-stage renal disease, not from a disability or from being over 65, lose their immunosuppressive benefit at 36 months after transplantation. So a lot of those folks then lose their allograft over the next year. We all learned about the increased risk of death and the cost when you transition back. It's not just a waste of the donated organ for the poor family and the person who donated, but it's a big cost to the system. So if you can get online, the American Society of Transplantation has a nice little link on their webpage. You can just click some buttons. You can email your representatives and say, please vote for something, save us money, and help our patients live longer. End of the commercial. Okay. So the number of transplants have been going up the last couple of years, unfortunately, because of the opioid crisis. And we all have seen this and know this, and those donors that have perished because of IV narcotic use are also considered, quote, increased risk donors, but they're being utilized. They tend to be a little bit on the younger side, and that's unfortunately been really the growth in deceased donor transplantation. Living donor transplantation really spiked when Dr. Ratner, who's now at Columbia, it was at Hopkins when I was there, really brought with Lou Cavusi lap donation to the forefront back in really the mid and the late 90s, and now that's pretty much also plateaued. As you all know, more than 2/3 of people who start dialysis never get listed for a transplant for one reason or another. Some of this is appropriate. There are people who have other severe comorbidities who wouldn't do well with a transplant operation, but we know there's others that probably do need to be referred. Even a transplant surgeon knows the 2728. And you all know that on the bottom it asks two simple questions. Has this patient been referred for a transplant discussion? And if not, why not? And then obviously, you know, if someone's listed, you need to keep up annually with the transplant center and know what their status is. But I think the point of this slide is to say, we do a lot of data collection about someone starting dialysis, and when they're on dialysis, and we don't pay all that much attention to, do we really get them into the pipeline to get into the local transplant center? Again, the pipeline is starting with end-stage renal disease on the bottom. Where do people fall off from attrition all the way up to getting their transplant? And unfortunately, as the saying goes, every system is designed exactly to get the outcomes that it achieves. Those of us in transplant are very highly regulated, and we're graded only on one-year transplant outcomes. And many of the next slides, I think, are going to show that. It's going to show why don't we not only list lots of people, but why do we discard organs? And the reason is that it means a big deal to our programs and actually to us personally if we don't hit the national regulatory guidelines. What this has really translated into is that people have come off the wait list. So centers have done a better job looking at people every couple of years, or especially when they come up to the time when they're expected to get an offer. A lot of us repeat cardiovascular testing all the time, echoes and stress tests, et cetera, see patients in the office. And as patients are diagnosed with either non-correctable, reversible findings on stress test or decreasing EFs on echoes, increasing pulmonary pressures, non-compliance issues, et cetera, they're being taken off the wait list. It's a mixture of both good and bad, again, depending on what you're looking at. 5-year survival rates, as you know, have improved significantly with dialysis, and probably even since '08, I would argue much more as people are doing home dialysis and doing more efficient dialysis. Transplant outcomes have also increased. All right? And to show how much we're really paying attention to the numbers, this is a good paper by Jesse Schold, showing that the mortality on the wait list has been declining every couple of years. Again, people looking at the wait list. It's no longer that someone's on the wait list for 6 years. The last time the transplant center saw them was 6 years ago, and now they're called in for a transplant. Almost always we've seen them within 12 to 18 months, and we've updated their testing. So more and more people are being taken off the list. The list is being more stringent, who actually can get me a good outcome with a transplant. And from both the mortality rate going down on the left and the removals going up on the right, you can see that. So it's pretty clear that this is a trend. So we can increase transplantation, number one, by getting more high quality donors, but also number two, perhaps by utilizing more of the donors we already have, but we don't use, which unfortunately is being, the term discard is used, but really not using a donated organ. So here's the number of discards in the purple line at the top. And as you can see, over the decade and a half, the number of discards has increased. Now, some of this is not straightforward because more of the organ procurement organizations are going ahead and procuring and going after donors who are older in age. So if I only went to procure an organ from a 20 to 40-year-old donor, I can immediately decrease my discard rate. But I'm also going to decrease my transplant numbers even greater. So we need to find a little bit of a balance here between being aggressive to go after some older donors and trying to use these organs better, but also realizing as we do this, the efficiency of the number of organs transplanted per donor will go down. Abnormalities as to why people accept kidneys or not, and I'm one of the people who gets the calls all night saying, do I want this organ? Number one, anatomical injuries do occur. Just a couple of weeks ago, I took one kidney, but the other one I was offered from the same donor basically had the upper pole almost excised because it was a rush DCD donor. And when they went to cut the cave out for the liver, they cut most of the upper pole, the kidney off. So of course, I'm not going to put that in a patient, right? But that does occur once in a while and is still a legitimate reason because no one's perfect. Other reasons cited, though, poor quality, and this is a concern. Sometimes it really is a poor quality. It's a 70-year-old donor who has 35 years of hypertension and diabetes and has proteinuria, and the creatinine on admission when they were stable was 2.5, and now it's 5. And I don't think anyone wants that kidney put in them or anyone else they know. So some of those are legitimate, but others are kidneys that may be good that have acute kidney injury. And the question is, how brave are you? There's a lot of good papers on this. So if you have a young person on a donor cycle who has no other known diseases in their 20s to 40s, and they go into AKI on dialysis and their creatinine is 5, do you want the kidney for yourself? Not do you want me to put it in a patient, but do you want it for yourself? Most of those will start up and work, but some of them won't. So the primary non-function rate is higher than the average, but most of them will work. So that's always a question in the middle of the night. We go from being people who talk about public policy to me saying, am I going to accept a kidney for Mr. Smith, who's number 1 on the list? And by the way, Mrs. Jones is second. Do I want a kidney for her too? Increased infection risk, we pretty much have spoken our way out of this. The new NAT testing these days, just so you know, for HIV and Hep C is highly accurate at 7 days after an infectious event. Most donors are in the hospital 3, 4, 5 days. You cut your window of risk to basically 48 to 72 hours. So I tell patients very clearly, the arithmetic says you're in more of a risk driving your car to the hospital than you are taking one of these donors that has a good NAT test being negative for HIV and Hep C. And of course, as you know now, Hep C is cured with 21 days, and some of us are actually transplanting known Hep C positive organs that have good biopsies into patients and giving them 21 days of direct acting antivirals, and they get a transplant faster. So you don't want HIV, of course, even though Magic Johnson is going on almost 40 years now with HIV. And Hep B is about 21 days, and that's why we beat on everyone to get vaccinated, and we can treat it, and we can use them. So the increased risk donor is less of a concern these days. Most of us will push patients to get this. I'd take them myself, so I have no problems doing that. Too long to find a recipient and no recipient located really means I have not a great kidney, and I really want to put this into a person who needs it for several years, not for 20 or 30 years. And it would be really nice if I have someone who's preemptive, because I know if I have a kidney that's in a little bit of slow function and I dialyze them, I'm going to put it into DGF. So you're looking for that perfect recipient for that donor. Sometimes it's hard to find at 2 o'clock in the morning on a Sunday. Sometimes it's not. So sometimes it's a little difficult to place those more difficult, challenging organs. And that's really the last two. So what are the system events? Actually, I was on this paper with my friends from Arbor Research, where we published on the Kidney Donor Risk Index and Kidney Donor Profile Index. And we used to do, remember in the old days, the standard donors and the extended donors. An extended donor was anyone over 60 or over 50 if you had a couple of other problems. This is a little bit more scientific. It looks at age, weight, et cetera, et cetera. And basically this predicts if you get an average kidney from a donor with a certain number, how long will the kidney last? So the lower numbers, the longer they'll last. The higher numbers, theoretically, the shorter they last. The risk index is then changed into basically a normalized scale, 1 to 100. None of us really think about this intuitively. We're all very, competitive in school. If I told you you got a 50 on a test, you throw something at me. 50 is the average kidney. No one wants a 50, right? So it's a little bit difficult when you get to the higher numbers, really. Over 85, 90, 95 is where we see a little bit tail off in the function. Maybe we need to do a little Madison Avenue and play with the numbers of how we advertise this, but it is something that some people say leads to discards. Here's the outcomes. On the left side in the darker green are the better kidneys. KDPI 1 means that kidney's better than 99 of the other average kidneys donated if you had 100 average kidneys. That's top 1%, right? Where we all were in school. And then as you go over, you got 10%, 50%, 90%, 99%, and then dialysis outcomes over those years. And what you see early on is that, is it really that much better to have an operation and get a 99% kidney? You're just barely over dialysis. If you look long-term, though, and you survive with that kidney functioning, you do get a long-term benefit. And a kidney with a KDPI that's high at 95, half of those kidneys last about 5 years. So these aren't useless kidneys. These are transplantable. They're just not as good. One of the big problems is that upper red dotted line, and that says regulatory threshold. So when you look at our outcomes, which as I told you before have been published since 1992, we have an expected 1-year graft and patient survival, and it's in the 90s. And so kind of the ongoing sad commentary is looking at a patient saying, got an 80% chance, I think I can keep you alive at a year and get you a transplant, but I need to hit a 90 to 95% outcome or, quote, flagged, I'm in trouble. And I still think that's a problem in this country. Here's the KDPIs on the bottom and the percentage discarded. So as you see, as you get over the magic number of 85, which is the new definition for an extended criteria donor or an ECD donor, it's now KDPI over 85. Does it have a stigma? Do they just get discarded because they're higher chance of not functioning. Also, probably one unintended consequence we had out of the new kidney allocation system in December of 14 was that we tried to go immediately to regional share for these over 85 kidneys instead of local. What it's actually meant is fewer of them have been transplanted. So it was opposite to what we predicted would happen. We thought that if these went out to the region, there would be more aggressive centers that would take them. And I think what we see now in retrospect, our center before the change used to take a lot of these, pump them and biopsy them, and have our real renal pathologist read the biopsies and use a lot of these kidneys and have time to find the right recipients. Now where I am in Florida, they go pretty much to Georgia, Alabama, Miami, and then come back to me a day and a half later. So we're seeing inefficiencies in the system with these kidneys. What's been confusing to people is this overlap of the KDPI or the KDRI in white of the donated organs and the discards in red. So sure, the mean is shifted to the higher numbers, but as you see, there's a huge overlap in what we would consider okay or good quality organs and what's discarded. Again, what's not in the KDRI or KDPI is who cut the kidney, how many vessels are there, did someone turn it down and it now has 36 hours of cold time. So there's only those 10 factors of the donor into the KDPI and not the other details. This slide, I think, is really trying to point out that not just do people obviously get discarded as they have more comorbidities in the donors, the standard strokes, hypertension, diabetes, infection, et cetera, but look at the bottom, biopsy performed. It looks like if you have a biopsy performed, you're more likely to be discarded, right? Well, some of this is a self-fulfilling prophecy because I'm never going to biopsy a perfect 25-year-old donor, right? That's silly. That's just all risk and no benefit. But also, as I'll show a little bit later, where the biopsy is read and when the biopsy is done is also important. So this is a paper showing that on deceased donor transplants, the bottom two lines, if you have, quote, an optimal versus a suboptimal biopsy outcome, they do separate with long-term survival. And I'll tell you flat out that we know that. Living donors a little less in the short term. Issue becomes this, and that's who's reading your kidney biopsy. So if you're doing a donor procurement at St. Elsewhere in the middle of the Panhandle, and the on-call pathologist comes in, they basically say, yeah, it's a kidney, looks okay. Basically, they can tell me it's a kidney, it's not a kidney, and it's not a cancer, and I don't see anything too strange, because they're not nephropathologists. And as everyone knows who reads biopsies, it's hard to read a frozen biopsy on a kidney in the middle of the night with people yelling at you, looking over your shoulder. Even for our expert transplant pathologists, it's not that easy reading a frozen biopsy. Where I used to practice actually in Carolina, our pathologist would beg, can you pump the kidney and I can get you an 8-hour rush permanent. And it's a much better read, as you all know. But as you see, as you move to the second panel B, if you get a transplant pathologist to read the biopsy, it actually correlates with outcomes. And the graph on the right under B also shows that. And as a little example, in my own center, we did a donor about 2 or 3 in the morning. The on-call pathologist, who was a dermatopathologist, read the biopsy, said it looks okay. And the renal pathologist came in, had him double read it at 8 o'clock, said, oh no, there's severe arterial nephrosclerosis in here. And I mean severe, and I mean everywhere. I'm not sure you want to use this. So again, this is like the old garbage in, garbage out. People who discuss biopsies, I think, do it unfairly because they want to talk about glomerular sclerosis, right, GS, and my joke is GS is BS. I don't care about a wedge biopsy and what the GS is. I care about what the blood vessels look like and a good deep biopsy read by an expert. And so that's a big problem and a big part of confusion, I think, in transplantation. This is also what's called the weekend effect. It's harder to place an organ on the weekend. And there's a lot of both system and other issues with this. When I'm on call for liver, kidney, and pancreas transplant. So if I accepted a liver and a pancreas, am I going to pump the kidney for 2 days and do the kidneys in 2 days? So some of this is system, and some of it may be others. What's also interesting, you notice how Sunday's real low? It's because we accept kidneys on Sunday and we transplant them Monday. I don't know about you, I have Monday clinic. I much rather be in the OR to do Monday clinic. So I'm going to accept all the organs I get offered on Sunday and early in the week. So this is an event that's occurred over the country. The question is, how can we kind of get around this and even argue for more resources to do this? You can eventually place most of these better organs, but it takes a lot more calls. So you get them with increased cold ischemic time. This slide discusses basically the odds of discarding a kidney or not using a kidney and how it varies across the different areas of the country. The title suggests that obviously where you have the highest stage of ESRD, it just so happens that a lot of kidneys are not used. And that is mathematically true. Also, what you will notice that same population that has a high rate of ESRD are, guess what, are donating to kidneys. So just as though in Alabama and rural Georgia, you may not have as many family members who are good living donors, the random population of deceased donors may also have more intrinsic kidney disease. Probably can do a better job with this than what we do, but that's also part of the details. So too many kidneys are discarded. It's hard to do a one-on-one correlation with organ quality and discard, and around the country things are done differently, and we know this. So patient preferences. So this paper says, would you rather go to a center because the transplant outcome is a couple % better or get a kidney transplant faster? And most people say, I want to get a kidney transplant faster when they think about waiting 5, 6, 7 years for a transplant. However, we all know that once they get the kidney transplant, they sure do want it to work. So this is a difficult question, and I wonder if this was also due as a trade-off. You know, would you wait 1 year less for a kidney with a 10% less outcome? That would be a very interesting study that I haven't seen quite done yet. So if someone wants to do that or get their smart fellows to do that, I think that would be a fascinating study. This just goes back to the quality of the data that we have. Organ refusal, organ donor quality is listed as almost everything. It's kind of a garbage bag. We're trying to fix this and get better definitions. We actually review our turndowns at our center, and if you work at a center, you have access to all your turndowns and you can look at those. So we actually try to put in there at 3 o'clock in the morning what we actually did. You know, creatinine was 10, or there were 3 arteries and Andreoni cut 2 of them. I'm not going to put it in. So we try to actually be a little more detailed so we don't have to go back over all the data and figure it out. So patients want to get a transplant faster, we know that, but the truth is they also want it to work. And we're not exactly sure why people turn things down. So this is interesting. This is a discussion about communication between dialysis centers and transplant centers. And red on the right says a percentage of kidneys offered to a deceased patient who is still on the wait list. So over 16%, there it says 18% of offers in 2015 went to patients who were not alive. So perhaps having a little bit of a better communication, and this does happen actually. Our last KP offer, we called someone up who was rather young and found out they had just died a month before. So a little better communication on both sides of the fence. I try to call the dialysis centers after we transplant patients, and I hope they call us when patients are no longer alive so we can get them off the list. So it goes in both directions. This is also wait time. I was surprised at the fact that the wait times are so inaccurate because most of us now go back to the Medicare databases and the wait times are now basically what's officially in Medicare. But this says that over 25% of people listed had more than 1 year error in wait time, and usually it was harming the patient. So they were on dialysis for 1 year more than they were getting credit for, so they were lower on the list. So that actually is a big event. That's something I think we need to fix with the software. Comparisons are interesting, and actually I was up on the Hill a month ago, and we got to use this data to lobby our folks about decreasing regulation, and that is we're falling behind the rest of the world. If you look at the organs that we use versus those used in the United Kingdom, they're able to use kidneys that theoretically or to a much greater extent that we don't. If you look at France, and this is a paper just out, and they basically looked back at the details of the donor organs and said that in France, if you looked at the same criteria they used, they probably would have used more than half of the kidneys that were discarded in the US over the last couple of years. Again, there's no regulatory oversight in any other country than the United States, just so you know. and that may be a big factor on this. And again, this is just a comparisons. If you look at them, again, some of this data is fudgeable. If I only go and procure healthy people, I'm going to decrease my discard rate. We don't want to do that. We want to get options to our patients and procure more organs. So in summary, currently 1 of 5 kidneys that we procure, we don't use, we discard. There's a large variation on where organs are used around the country. Other countries tend to use more of the less than ideal organs than we do. And there could be better communication across the board to try to make things better. Some things that are in play now are warm perfusion technologies. You may know that many of your transplant centers will cold pump kidneys, and therefore we can have people fly in from out of town or drive in, they're 5 or 6 hours away. It's also a way of looking at the resistive index of the arterial bed on the pump, and it does predict function. It does predict relay graft function, et cetera. Now a big push actually started in the UK and in some of the areas around Switzerland, et cetera, Netherlands, are looking at normothermic perfusion. So what we do when we cold perfuse is we keep things from dying. We may get the ATP up a little bit on a cold perfusion pump. But if you use normothermic temperatures, you actually get cells to be alive, theoretically, to function, to regenerate, and they actually will utilize oxygen. So for things such as the big push right now is for livers, and if you put livers on these machines, they look like heart bypass machines. You need not only to give them oxygen with blood because they have such a high metabolic rate, but you need to give them TPN, and you can watch them work. People have also pumped kidneys, and they can actually measure creatinine clearance. They can watch the kidney work. So this is something we may be getting to actually in the near future. And so it may be a better way of looking at these organs. Because still in this country, when we transplant someone, we have a failed graft, we consider it a failure, right? It's a really severe personal failure. It's hard for us to accept failure. If you knew the organ was working, or maybe I need to put both kidneys into this patient and not one to get an acceptable GFR afterward, it's probably a little bit of an easier pill to swallow there. So something that's probably coming to a transplant center near you. So thank you. I hope I did justice to his slides.